Sweet. So firstly, where actually do the VALD assessments fit? And this one's a really obvious one, but I've thought important to bring up anyway. So when we look at what we go through with a patient, your subjective history, and your objective assessment, this is where the VALD testing stuff fits in. It's part of our assessment, and it's a tool that we use to sort of enhance our assessment. So yeah, as far as your SOAPy notes, for example, from uni, it's in the O section. It's the objective testing. That's what the VALD assessments are. Why do I think, and this could be just a theory I've got, but why do I think that it's actually a bit of a challenge and overwhelming to implement it, is because I think traditionally what podiatrists are really good at, and what we do, is we add tools to our toolbox to help with treating people. And this is VALD assessments are a tool to actually assess people. So potentially that might be where, we go off and do our dry needling courses, we do our foot mobilizations, we learn about shockwave, exercise rehab, the P3 course, we get better at orthotics as we go, but maybe we don't add a lot of stuff to our assessments perhaps. And that's just a theory I've got. So yeah, Andrew, anything to add to that? Maybe I just come up with that theory last night. I thought maybe, we don't traditionally add tools to our assessment toolbox, apart from our clinical experience over time, perhaps.
Yeah, I think the only comparison I can think of is like physio. They do seem to spend a lot of time on the assessment parts. I mean, you think about how much time Jen spends with her team on the neuro assessments and getting them down to 90 seconds and things. So perhaps that is just a part of podiatry that maybe there's some things like diabetic assessments that we get trained on a lot at uni, but maybe the other stuff not so much.
Yeah. So like the VALD stuff, or objective testing with force frames and this technology, VALD's just one of the brands. There's other brands that offer it, but VALD tends to be the best at the moment. They're really dominating the market and have the best stuff. So it's been around for a long time in performance spaces. So athletic performance, strength and conditioning, exercise science, it's always been there with that for a number of years. And now it's starting to come more into allied health, and physios have been doing it for a lot longer than podiatrists have, but it's definitely not a physio thing, right? This is a objective testing thing, and we can do it as podiatrists and be just as good as the physios at doing it. They've probably just had a bit more early exposure to it and been doing it for longer. So that's where it sits. But that's just what I've thought maybe. But besides that, it is also, there's a lot of stuff in the VALD. So what I hope to get out of today's session is just really simplifying it as much as we can. So don't be overwhelmed by all the metrics and all the different tests you can do. Let's just really try to simplify it and just get used to using it, and then we can get more detailed and nitty gritty with it as you go on. So there's 3 reasons why you would use the VALD assessments, I feel. Number 1 is to determine the current status of the patient or the athlete. So again, just objective testing, how strong are they? Where are their deficits? Where are their asymmetries, left compared to right? And is that correlated with their presenting complaint? To develop a baseline sort of status of where they're at in regards to those tests. The second reason would be to then, based on reason number 1, is what do we do? Right. So it's all well and good for the test to give us a number, give us a score, give us a ratio, but then what do we actually do with that? So that's the second part, is the VALD testing can actually inform what exercises you give someone, what areas you need to target, and also whether or not they're ready to progress on to the next stage of their rehab, right? It's whether they've, if they're strong enough to do a plyometric, for example, what sort of strength score are you looking for? Perhaps, there's a number of different applications there. And thirdly, to then determine the effectiveness of those original rehab decisions. So is what we're doing actually working? So when you test someone 6 weeks later, have they actually improved in their strength? And if not, what's going wrong there? Is it a problem with your decision to give them that exercise? Was it not the best one for them, or are they not doing their rehab? There's lots you can unpack there, but they're basically the three reasons you would use it. And that's for any objective testing, any monitoring process. Yeah, they're the three steps you sort of go through. So determine where they're at. Then what do you do with that? How does that inform what you're actually going to do for them? And then how do we assess whether that's actually being effective? And you can get all of that out of the VALD stuff. But there is a fourth reason as well. I thought I'd throw in a little surprise. Number 4 is you can improve buy-in and adherence and trust by, you might know that you can need to improve their strength, but the patient may not believe you or not quite understand. So yeah, you can't hide from the numbers. So any thoughts on that or questions, Addie? No.
No, all good. Basically makes sense and covers everything like that we spoke about yesterday. So just refreshing on that. Yeah.
Yeah. Great. Tess, any thoughts on this one?
Yeah, no, that all makes sense. That's good, yeah, concise sort of reasoning for it. Yeah.
Yeah. Cool. So we'll get stuck into an example. So I had a 36-year-old female come in last year in August, left medial ankle and arch pain, mostly the arch pain, like around that sort of tib post insertion area. But she was fine day to day. Walking was fine. Getting around was fine. Everything in the gym was fine, except for her higher impact stuff. So whenever she hopped or jumped or went for a run, she'd get this medial arch pain. It wasn't really stopping her. Like, she was able to push through it to an extent. But yeah, definitely wanted to get it sorted out. So Chris Dawson actually referred her to me from Authentic Health. And her goal was to be able to do all those things, mostly running. Interestingly, though, yeah, over a year prior, she did have a pretty severe inversion ankle injury on the same side. So lateral ankle sprain, severe grade 2, like there was MRIs and stuff, like they were suspecting all sorts of stuff, but it was mostly clear, just a really bad ATFL, CFL sprain. Took a long time to rehab, and I've actually watched her rehab it in the gym, like, because when I go and train out there, I often cross paths with their clients, and I've been seeing her do her rehab in the gym there as well. So I've sort of been following it as an outsider for a while, and yeah, then she presented to me with this arch pain. So yeah, this was sort of where she was getting the pain, a bit more plantar. But yeah, definitely medial, and it wasn't plantar fasciitis pain. It was more up towards that tib post sort of area. And so yeah, maybe it should be more around here. And she was getting some through the ankle as well. Now, this is the question I sort of asked her, or how I kind of communicated, basically in a roundabout ways. So I'll put this together. I think this is what I would have said. So basically, you can ask them, have you ever had your strength tested before? No. Well, because you've had that ankle injury recently, I feel it would be a good idea for us to see if there are any deficits left that may be contributing to this new pain that you're getting. How does that sound? So yeah, put it to them simply like that. Another thing is, like, if you're working with someone from the start of an acute injury and their pain has come down, you can be like, hey, great. Now step one is sort of, we've got this pain down, which is what we're trying to do in the first place. Now I really want to actually assess your strength to see see how much further we need to go and to plan the next stage of your rehab. How does that sound? So yeah, that's kind of how I would frame it and communicate it. Just yeah, and that could be at any point when you feel it's appropriate to test. I feel if they're if they're acutely flared up with injury, then you probably want to settle that down first before you do any strength testing. Purely because, one, you don't want to aggravate the pain. Two, because they're probably not going to give you a reliable test result if they're in pain. So yeah, settle that acute pain down, and then yeah, test them so it shows them where they're at, and then you can compare that to where they should be. So yeah, so these are the tests that we did. So my reasoning for doing these tests, so I did an ankle inversion, I did an ankle eversion, I did dorsiflexion and plantar flexion, so a seated calf raise. Really simple, just all the muscles around the ankle, because she'd had that ankle sprain previously, and she'd rehabbed it for a long while. So I just had a feeling that with this particular issue going on, there was probably a deficit there that has been missed in her previous rehab, that something we need to really tidy up. And she's not an athlete. She's not, yeah, she's not unfit, but yeah, she's not an athlete. So her test results were all down compared to the normal of where she should be. And that normal came from the previous AXIT values that we used to use. But now there's a lot of normal data on the VALD system as well, but not for everything. I think it's still evolving. But based on what I've felt was normal, all of these scores here are well down from where she should have been. So there's a huge opportunity there for her to improve her strength overall. But what was most interesting was the 25% deficit on her left symptomatic side with the inversion. So she was getting medial arch pain, medial ankle pain, and her inversion strength, so the tib post muscle essentially, on the affected side was 25% down on the non-affected side. So that was my main finding. It correlates with her symptoms. So yeah, that's the main one that we ran with the rehab targets. I still wanted her to work on calf strength, because we want these numbers here to be closer to this one. But the main deficit as far as symmetry was the inversion strength. So Tess and Tom, does that make sense as far as linking what I found in the test to her symptoms?
Yeah, it does. Yeah. On a side note, so that normative data, is that for athlete population or for general population? Because I feel like it's for athletes.
Yeah, it's for athletes.
So are we aiming everyone to be an athlete?
Just as close as you can,
General
basically.
pop.
Yeah. It's all contextual, so it depends on the patient, where
Yeah.
you can make your own judgment there. But I think the VALD normal data stuff also has like population groups, so ages, sex, all that, and that's continuing to evolve on the VALD hub as well. Yeah, Andrew would probably know more about that. Were you still working with that guy on this?
He's working with Alicia actually as well. Bo, his name is. There is movement on that. I think that's the thing that they're really wanting to try and do, is make this data relevant. So Jackson's looked at this and found asymmetry, and that's obviously one conclusion you can draw from it. But then there's the actual raw data, and at the moment that raw data is a little bit kind of hard to compare. But there is work in that, and the more people go out and test, the more information they get, they can start to get some data. So for a 30-year-old female, non-athletic population, this is what her normal data should look like. We're building that as at the moment. So hopefully we will get to a point where, yes, you'll be able to say, for someone of your gender, your age, you should be at this or around about this number. And that's, I think, where it can be even more useful. than what it currently is.
Yep. So in this instance, yeah, I was talking about these normal values, which were from the AXIT poster we have on the wall of all those values. And this is all measured in newtons. So newtons is basically a measure of force, whereas kilograms is a measure of mass. So 1 kilogram is 9.81 newtons. So yeah, but the main thing you have to understand there is, yeah, kilogram is mass, newton is force. So a newton is actually a measurement of how much force is required to accelerate a mass. Yeah, so mass versus force, that's pretty much all you need to know there. So this was after the initial testing. So my actual notes, the main finding was an inversion deficit on the affected side. So what we did with our rehab was we started inversion strengthening, TheraBand inversion, because she's quite weak. So really wanted to target that tib post, got her on the TheraBand. And also tib post bias to calf raises. So a calf raise with the band around the foot, pulling the foot into eversion, so that she had to use her tib post to correct that. And that's on, I'll show you that in a second, but that should make sense. And medial hopping. So when it comes to tib post and perineal strength, hopping and jumping laterally is a really great way to strengthen those muscles, because it gets to a point where you can't really, you can't really do too much more with like a band. So yeah, what I find is when I get them doing hopping, jumping, plyometric stuff, you retest their strength, and it just exponentially improves. So so she was quite weak with inversion, but she was actually already doing some hopping stuff in the gym, and she was able to tolerate a little bit of it. So I advised her to keep doing that as much as she could tolerate, because she wasn't really doing herself any damage. So I thought she can continue this, but then if she's doing this as well at home on a daily basis, then eventually that's going to catch up. The strength of the tib pose is going to catch up, and then it'll just bleed into her being less pain with the hopping. So so this was test one, the one that we just went through with the inversion, and then I tested her a month later, and there was still a big deficit, but the scores with inversion had gone up. So that was really great to see. Again, helps with that trust and buy-in that what we're doing is working. So yeah, that was good. So does that all, and this is what you pull up on the VALD hub. You'll be able to see these graphs. But also when you're on the screen on VALD, it'll tell you how much improvement there's been as well from last time on the iPad. But this is straight from the hub. So yeah, so good improvement, like both sides improving. That's great. I was talking to Addie yesterday. I think when one side is significantly weaker than the other, you'll find the weaker side will improve in strength a lot quicker than the stronger side. But in this case, because they were both relatively weak, they're both improving a lot. So yeah, that all makes sense, Tom? Yeah, cool. So yeah, so we've got an improvement. This was a month later. I saw her because she was already in the gym, wasn't hindering her daily life really. So I wasn't seeing this patient every week. Wasn't doing any treatment or anything. So I just did the testing, prescribed the rehab exercises, got her to come back to do that all again a month later. So yeah, 25% improvement both sides. Asymmetry was still the same, but overall improvement. So got her doing a bit more hopping and landing stuff because she was able to tolerate it. So, and we progressed her TheraBand inversion and tib post calf raises, just got her doing them a lot heavier, with some weight as well with the tib post calf raises. And this was the improvement a month later. So again, that's that inversion strength. Now we've got no asymmetry or hardly any, and yeah, both have improved a lot. So yeah, that's a really successful case of found the deficit. We worked on an isolated muscle to build that strength up, and now we've reduced the deficit. She can see that, gives me more confidence that we can progress with some harder plyometric stuff, because I can see when she was doing the plyometric stuff, she was getting better at it as well and in less pain. So yeah, all of this basically supported my. So if we go back to the 3 steps, like that third step is what we're doing actually working. So yeah, it was. So yeah, it gives you and the patient more confidence, basically. So yeah, 50% improvement. Asymmetry is now within 5%. Great. We also tested the calf, and there was a 20% improvement. Yeah, so that's this one. So left side calf strength, we were able to get that up as well. Right side, we were able to get that up. So remember the normal value for her for her calf strength was like 900 and something. So yeah, from where she started at 5 and 6, we're getting closer. Still got some work to do. She's now doing some really heavy seated calf raises to really chase this calf strength now, because I'm not too worried anymore about the tib post. So and also, yeah, we're adding some skater hops, lateral depth landing. So doing a lot more plyometric and lateral movements, because her tib post can now handle it, which is great. Where it's also useful, and this is what happened a couple of months later, because she went on a big overseas European trip. So, and she come back saying she was a bit sore through the arch again. So, yeah, she was probably a couple of months, 21st, yeah, it's almost 3 months since I last saw her. So because of her holiday and she's been unwell and that sort of thing. So we retested, and I tend to find this quite a lot, and certainly with my own rehab from my ACL, is that the weaker side, the deficit side, drops off a lot quicker. So whenever you have some time off the gym or illness or whatever, if you've got a deficit, previous injury somewhere, that side will suffer quicker than the other side. So you see, she was able to maintain that right side strength, but the left is way back down here again, which is not great. So bit of a setback for her, but again, yeah, this is just part of the monitoring process. Does anyone have any questions about that? Andrew?
Were there any signs to her post holiday and illness that her symptoms were coming back sort of to correlate with that strength production?
Yes, yeah. So she was feeling a bit sore when she was getting back into the gym. A little bit of pain, a little bit of that original arch pain. It was starting to creep back up again. So yeah, that's the reason. Like, we had the testing planned anyway, but once I saw that the inversion strength was down, because she hadn't been in the gym much at all over the past couple of months, so I expected it to be down. I didn't bother to test her calf strength, because I knew it would just be sort of the same finding. So
just again, what with that though, like because if you looked at, say, the third test, you'd be very happy to discharge her. You've seen some good strength gain, but were you happy to discharge her at that point?
No, it wasn't discharge. So we still this testing session was planned. So I knew that she was going away. I knew that she was not going to be in the gym for a while. I wanted to, because we still weren't there, right? So her calf strength was still not good enough. Like, I want this to be up here. She still wasn't back running. So that was our goal, to get her running. So yeah, so I was still working with her, despite the fact that this was looking better.
Because that's a really good illustration of, you might, and I think a lot of us are guilty of this. You might discharge someone at that point, and you can see how quickly, in a very short space of time, that they're almost back to square one. Not quite, but not far off, and the risk of obviously it relapsing is pretty high.
Yeah. No, we hadn't achieved all of our goals. She wasn't back running yet, so this was purely from a strength point of view. So still working with her. And inversion strength is down. Did not test seated calf, as likely the same. We were doing we did try some different stuff because she's starting to get anxious about getting back to running. Like she's getting a bit annoyed that she's not running yet. So I got her doing some low level dribbling, ankling, running stuff, and she was able to tolerate that fine. But basically I advised recommencement of her current program that we were doing before. And this is what it looks like now. So still doing an inversion, heavy. So it's not a yellow band. She's got like a black band, possibly black and blue, like a double band. We're doing seated calf raises, heavy, and some running, drilling stuff. So less impact. She's not running yet, but I wanted to introduce some of it for her, and she tolerated it fine. She was able to pogo jump, but single leg pogo jump was really poor. So I haven't assessed that yet on the plate. So I was just qualitatively looking at her doing pogo jumps, and they were really poor. So I didn't bother testing it because I wanted to tidy it up first with some exercises to improve it. And once she's starting to improve, then I'll actually test to see where she's at. That's basically that. The one thing about PhysiTrack I don't like is you can't go back and see their previous exercise program versions. So this is just where it's at now. It would have been good to be able to show you at each testing stage what we were actually doing, but she's got a pretty good program now. So what's next for her? I'll assess her hopping, like I said, her reactive strength on the plates, and we'll get her running as quick as we can. She's back into it now, diligent in the gym, 3-4 times a week, doing all the stuff. So I think she'll turn it around really quickly. And so basically, just to finish up quickly, I think what we can focus on is hopping based on what their capacity is, whether it's double leg or single leg. Do hopping on the force decks. You see the calf raise on the force decks, and your inversion and eversion on the new force frame. They're our core four. I think we should really focus on nailing first. And then there's all the
additional ones you can do as well. But if you're going to
I've lost you, Jackson. We lost you. We had a bit of Mickey Mouse there for a second, and then we've lost your audio.
You turned into a chipmunk for a minute.
Yeah.
Jason.
Just blowing up. How weird.
You good? Think is coming in here.
All right.
No, welcome. Come in.
I think my computer just like blew up or something. I don't know.
Is it like even turning on?
No.
Oh,
Yeah.
good.
Do you have the access to the slides?
Did we have more slides to
No,
go
that's
through?
it. That's it. We're all
All right.
done.
That's weird. Anyway, all good. Thank you very much for doing that. So what I just wanted to say before we all go is this is sort of setting up the next block of the focus for us, as it's going to be then getting hands dirty and actually getting in and playing around with it. I think what Jackson set up really nicely is like using current examples, patients you're currently treating or you've previously treated, about how we can integrate it. I think that's a really really simple example of how useful it can be in determining. And like I was, just some of the things that you said there, Jackson, about, being able to track the progress, and even if it's slow, it's that knowing that you need to keep continuing on with the program to see it through, and the effects of, I never realized the effects of how significant it can be just with 4 weeks off, of how you can almost go back to the start. And that's a pretty good sort of reminder for us as practitioners, as well as for the patient, to go, hang on a minute, like you're not ready to go back to running. The chances of this relapsing is so high. So I think it's a really awesome tool. I think we've just got to get familiar with it and just do it as much as we can. So when you ever get a chance, you've got a white space, when you're out there, Tess and Tom, and you've got some shared white space in the diary, just go out and test each other and get familiar with it. Use the handheld dynos and those sorts of things. There's some cool things coming up with the actual, as I said, that normative data, which we'll go through. But yeah, I think that should be a sort of a really fun next little block on using this technology. So play your role. Thanks so much.
Bye.